Hi, everybody. Welcome. My name is Giancarlo, and tonight's training is going to be on deliberate practice, implementation, and integration. So what we've been talking about thus far has to do with how we can improve as clinicians, and how we can utilize feedback from our clients and outcome data to help us to improve outcomes for our clients and improve our services that we provide to the clients and their satisfaction with the services. So deliberate practice has come from feedback-informed treatment, and they're linked. So we'll get into a bit more with the connection between the two, but tonight is all about deliberate practice. So again, my information here, and I'll send everybody the slides as well. I'm hoping everybody got the last slides from last week and the other weeks, but if anyone needs to get in touch with me, please don't hesitate to call, email, anything. And as was the case in the last several trainings, please, if you have questions, thoughts, comments, concerns throughout, just interrupt me, just say, hey, Adam, and then go on with your question. We're going to have some breakouts about maybe halfway through or so. You'll be pairing off and we'll be doing a little role play kind of stuff. So, and then there's going to be a group discussion at the end. So, this training, so a brief description and outline of what this training is all about is it's going to introduce you to the basic concept and the phenomenon of deliberate practice, or DP, and its origins, its significance, and it'll educate you about the benefits of implementing and integrating DP into your work. So what we'll be doing is we'll be encouraging you to be introspective, to reflect, to contemplate regarding your strengths and weaknesses as a clinician, which are not always the most comfortable thing to, necessarily think about. What are my sort of, weaknesses or shortcomings, or what could I improve upon? But it's going to be, we're going to make it comfortable. It's a comfortable thing, when it comes to deliberate practice, when it comes to feedback-informed treatment. So, and how we can grow and develop professionally. So this is a safe space. This is a space where we can be honest and open with ourselves and with each other. So when it comes to what we feel we could improve upon, or what could get better as far as our practice goes. And that's, I think what we're all attempting to do or working to do throughout our careers, hopefully. So you will consider your assets and shortcomings regarding your clinical work, and will work toward initiating an individualized professional development plan, or PDP, to help you work towards improved outcomes and progress for your clients, increased client satisfaction with your services, and subsequently greater effectiveness as a clinician. Now, when we're looking at these things, the outcomes and progress for our clients, client satisfaction with services, and effectiveness as a clinician, these three items are sort of like a virtuous circle. They all connect at some point, and so that's what we're looking for and we're hoping for when it comes to feedback-informed treatment and deliberate practice, is all of these phenomena to occur: improved outcomes, progress for our clients, client satisfaction with services, and then effectiveness when it comes to our clinical skills and abilities. So some of the learning objectives: we will evaluate our effectiveness as clinicians in a general sense. And that will be based on the feedback that we've been receiving from our clients and also from our own personal insights and reflection. Now, I'm assuming that, some of you have talked about some of the data collection that you've already been doing as far as utilizing the ORS and the SRS, and that's great. And if you have any of that and you want to incorporate that, that's definitely great. However, I know a lot of us may have not gotten into the data collection and tracking and outcome reporting necessarily yet, but the feedback from our clients and our own personal insights and reflections, and also anything that we've discussed during a clinical supervision with our clinical supervisor, or if we have like a coach or a mentor, those kinds of things. So we'll have a clear sense of our practices that have been effective, and which aspects of our service provision could use improvement or attention. So this is all about sort of evaluating our effectiveness and, what we're doing that has been working and what hasn't really been working so much. And so it does take, again, honesty, openness, when it comes to, self-evaluation and self-assessment. So we will develop a path and direction for improving our own effectiveness as clinicians, thereby helping our clients progress and experience better outcomes. So, where did deliberate practice come from? DP was developed by K. Anders Ericsson, PhD. He's a Swedish psychologist. Tried saying that 5 times fast. Ericsson spent over 30 years studying the habits and behaviors of experts in various fields, from everything from chess to music to medicine and surgery, computer programming, history, sports, business, bridge, physics, dance, typing, and even juggling. And what he found was that what all the experts seemed to have in common was engagement in what he called deliberate practice. So what is deliberate practice? It's behaviors engaged in consciously and with intent, repeated over and over in an effort to improve. How he defines it is individualized training activities, especially designed by a coach or teacher to improve specific aspects of an individual's performance through repetition and successive refinement. So what happened eventually was the role of DP is first linked with psychotherapy effectiveness, not until 2015 by the International Center for Clinical Excellence. Although there's been much research following that. And Scott Miller just happened upon the idea of the concept of deliberate practice when reading a magazine or an article in Fortune magazine, and on a flight that he was taking. So it was kind of happenstance, but it was serendipitous. I think that's the word that he uses for it. But it was connected with feedback-informed treatment, and they go hand in hand because In order to improve, we need to measure our baseline and establish our baseline performance level. And from there, we can determine our individualized learning objectives. And moving forward, we can then make adjustments based on a continuous stream of client feedback and based on analysis of client outcome data gathered, tracked, and reported routinely and systematically, like we've been talking about in the last few trainings, and then also based on engagement and personal reflection, contemplation before and after sessions about what worked and what did not. And one major aspect when it comes to that is one of the things that they have found in the research into deliberate practice when it comes to clinical effectiveness is how much time clinicians spend before and after sessions with personal reflection and or contemplation and or evaluating or analyzing, assessing what they did during the sessions and how they could possibly improve. That was a major factor as far as effectiveness goes. So the more time spent, the greater the effectiveness. Open and honest discussions with a coach, supervisor, mentor, as well as other supports, both personal and professional. This can be, you know, a situation where we receive help from different sources. It doesn't need to necessarily just be professional colleagues and or supervisors. People can help us when it comes to, you know, issues that we may be experiencing as far as what's going on with our clients or what's going on in our clinical and professional world. So, you know, we can receive help from various different sources in addition to our own personal reflection and insights and contemplation. So the connection with psychotherapy effectiveness has to do with Scott Miller and many of his colleagues applying what they knew about the contributing factors to positive clinical client outcomes. And a lot of this comes back to Lambert's common factors. I don't know, are folks familiar with the common factors? Anybody? Okay. So what Lambert did was studied the various different factors that contribute to positive client outcomes. And what they found was 40% are actually client and extra therapeutic factors, which we have no control over. These are things that are going on in their lives that we, you know, can't affect as clinicians. Then 30% of what the contributors to positive client outcomes is the relationship between the client and the clinician. So the therapeutic alliance. And then, so that's a big chunk. That's a, you know, that's a significant portion of, you know, what can affect positive results for clients. Then there's also a placebo effect and hope and expectancy, which we can have some control over. We can help to instill hope and expectancy in our clients, and we can, you know, help to help them find, assist them in finding some hope, and or, you know, motivation and movement towards goals, that kind of thing, in the hope that they can succeed or get to where they want to go, achieve the goals that they set for themselves. Then models and techniques is 15%. So what they found is that, it's not necessarily what model you use for what diagnosis, as far as therapeutic interventions go, because the relationship actually kind of trumps all of that. But models and techniques are important. They have a place as far as, what to use when and in what situations. So every clinical situation is individualized, but these are the common factors when it comes to therapeutic outcomes. So they then developed a template for focused, deliberate practice activities that can lead to professional skill development, growth as a clinician, improved outcomes and greater progress for clients, and greater client satisfaction with services. Again, this virtuous circle. So what they found was they broke it up into 5 different activities in therapy. And as I go through these, if you have a little pad or something, make some notes about some of the questions that might be helpful for you to ask yourself as you continue in your practice. So structure: how do I start and close a first or a subsequent session? How do I elicit detailed or nuanced feedback and integrate the use of feedback measures into therapy? And how do I prepare for a planned closure for therapy? Hope and expectancy: how do I conduct an induction into therapy? So especially in the first session or early in the therapeutic relationship, expectations and roles. Am I clear about what's expected from them, what they can expect from me, what role I'll be playing, what role, they'll be playing, and then a realistic assessment and treatment planning should be coming from this discussion. And do we convey a sense of hope, optimism, confidence, belief in our clients and our treatment approach? Because these are important aspects as far as outcomes go. So we want to, again, convey a sense of hope, optimism, confidence, belief. Of course, we don't want to be overconfident and arrogant or conceited or just, those kinds of things, but we want to have some confidence and some belief, and we want to believe in our clients and we want to believe in our approach. So alliance: how do we establish, and there's a lot that goes into this, but how do we establish and work toward goals with our clients? How do we communicate empathy, warmth, understanding, and acceptance with our clients? Positive regard, unconditional positive regard. How do we handle a ruptured alliance or other difficulties with our clients? Client factors: how do we tap into our clients' strengths, abilities, and resources? So these are important factors that contribute to positive outcomes. Their strengths, their abilities, their resources, and how do we tap into those? How do we work with and utilize their values, their beliefs, their cultural systems? So how do we connect with those or again, utilize those? Then therapist factors is the last one, which is our own personal sort of experiences as far as how we regulate, manage, or handle our own anxiety in session, and or if we're having any countertransference issues going on, how do we utilize self-disclosure with clients, and how do we engage in solitary deliberate practice outside of sessions in our typical work week. So take a moment, and if there are any of these questions or areas that are significant for you that you might want to explore or think about or consider when it comes to your own practice, anything that stands out as something that you might want to think about, consider, explore, make a note. And I will go further into detail with some of these questions, specific questions when it comes to these different areas. So the theme, one of the themes, again, the structure. So starting a first session, starting a subsequent session, how do I do it? How do I close a session? How do I elicit detailed and nuanced feedback? How do I integrate the use of feedback measures into therapy? How do I prepare for a planned closure of therapy? This is from a chart, a handout for Taxonomy of Deliberate Practice by Scott Miller and Daryl Chow. This is specifically for supervisors. And they have, you know, your rating, again, sort of a scale rating, 0 to 10. How am I doing in these areas, or how is my supervisee doing in these areas? And then ranking activities to work on, and then any notes that might be important when considering these areas, these questions, these activities and themes. So hope and expectancy, how do I conduct an induction? What to into therapy, optimizing expectations of therapy. So am I, you know, talking to them about what to expect? Am I explaining the role of the therapist, the role of the client? Am I providing an acceptable and adaptive explanation for the client's distress? Am I connecting and really sort of understanding, you know, where they're coming from or what their distress is about? Am I providing a treatment plan rationale that's consistent with the explanation of the client's distress? So, yeah, a lot of times when people talk about treatment planning and using, you know, the client's verbiage, using their words in the actual treatment plan to help connect. How do we communicate a hopeful and optimistic stance towards our client? So, and, you know, focusing on their strengths and resources, abilities again. And how do we communicate that and express that we have hope for them, that we are optimistic about their ability to improve, to succeed. How do we convey a sense of confidence and belief in our own treatment approach? So how confident are we as far as when it comes to our approach? And as we continue along with feedback-informed treatment and deliberate practice, I think we do become more and more confident in our approach because it's backed up by evidence, it's backed up by tangible, quantitative and qualitative data that, you know, is relevant. So next is the alliance, which is very key again. How do we establish goal consensus in the first or subsequent sessions? How do we help a client who has no clear goals in therapy? How do we mobilize clients' willingness to engage in a therapeutic process or activity? And again, as we're going through these questions, maybe jot down a question or two that, stands out to you as something that you might want to explore for yourself. How do I encourage my client to face, experience, and deal with their problems? So that's the effective focus. And then the impact factor is, how do I explicitly convey warmth, understanding, and acceptance towards my client? Again, the unconditional positive regard. How do I promote emotional engagement, bond, real relationship, emotional safety with my client? What are some, actual tangible things that I do or say? How do I convey that? How do I explicitly communicate empathic attunement? How do I deepen my client's emotional experiencing? And how do I provide a corrective emotional experience with my client? Then as far as motivation, how do I assess and work with a client's readiness for change? And, we talk about stages of change, especially with problem gambling clients. This is key, this is important. Where are they as far as their readiness, their willingness, their motivation? How do I increase homework compliance? Am I giving, homework assignments? Am I asking the client to do things between sessions and monitoring that? Difficulties as far as the alliance. If there's a rupture, how do I deal with that? If there's an angry client, how do I deal with that? How do I deal with it when a client is feeling hopeless? How do I deal with strong and difficult emotions arising in the session? We may not necessarily think about these things, but it's good to think about these things on a regular basis. What's effective, what's not, and how is the client interpreting what I'm doing or saying as far as these things go. An example, I have someone that I know who was telling me about an experience with previous therapists as a client, and she was remarking about how one of the previous therapists that she had really stood out to her as somebody that she made a strong connection with, and that was very helpful and beneficial to her, as opposed to the other clinicians who she felt didn't, I guess, care for her quite as much or have as much empathy and or sympathy, acceptance, unconditional positive regard, those kinds of things. Because, for example, when she had a miscarriage, this clinician, when she shared the information with her, she could feel that the clinician was starting to almost get tearful. So she could feel that energy, that the clinician was really there with her, and wasn't just, doing her job, and wasn't just, sort of being there and not really being present or with her. So it's those kinds of things. So those are strong, difficult emotions arising in the session. How do we deal with those? How do we, connect with clients when it comes to that? How do we manage a client who's high risk of suicide? How do we manage a client who is mandated for treatment? And often, as we've been talking about, problem gambling clients, mandated, whether it be, by somebody in law enforcement, or whether it be a family member, a spouse, parent, child, or otherwise, so sibling even. But and then there are levels of the mandate, like we've talked about. Sometimes people are skeptical coming in, but they, notice and recognize and accept and acknowledge and admit that there is some kind of a problem, something going on, and they're willing. How willing are they? Client factors. How do we tap into our clients' strengths, abilities, and resources, like we talked about? How do we work with, utilize their values, their beliefs, and cultural systems? Like sometimes people shy away from this, clinicians, because, they either, don't want to offend, or they don't understand, or they don't want to self-disclose, or so there's, sometimes a barrier there, or an obstacle, or a gap, and or a distance. So how do I work with these things? How do I utilize these things within my practice? So questions to ask myself. When it comes to the therapist factors, again, the use of the self. How do I regulate my anxiety in a difficult interaction with my clients? How do I manage my countertransference towards client? How do I activate reflective functioning in session with my clients versus being reactive and rational? How do I utilize self-disclosure, like I mentioned? And then, outside of sessions, am I engaging in some solitary deliberate practice in a typical work week? So I will send a copy of that handout, and it's got space for, and again, it's for supervisors, designed for supervisors, but anybody can use it, and it can be helpful to anybody also. So, and they talk about stretch goals, they talk about SMART goals, review, and reflection. So the top 3 activities that, were listed in the chart that we want to work on are identified as our stretch goals. So we want to list them in order priority, and then it's highly recommended to just kind of narrow it down and focus on just one stretch goal. And it should have leverage on improving outcomes based on existing evidence in the literature. And there's probably going to be a discrepancy with what we identify as our stretch goal or goals and what our supervisor has identified as a stretch goal or stretch goals for us. And that's a great place for a dialogue. So talking about, what could I benefit from working on? And it's an iterative process. So it's ongoing, it's never ending, it's repetitive, but you're going to revise it until it fits closer to your learning needs. And, as you go along, you're going to develop new and different stretch goals. And then use the SMART goals, which is specific, measurable, attainable, realistic, and a timeline to assist you in developing concrete activities you can engage in to reach your stretch goals in a given time frame. So what specific, measurable, attainable, realistic activities can I engage in to achieve what I'm looking to achieve as far as my stretch goal, and in what time frame? How long, should I give myself, or should I give my supervisee? So we're going to keep our eyes on our stretch and SMART goals, and we're going to remember to set aside a specific date and time to review our professional development plan with our supervisor, and that's ideally done in the presence of client outcome data. So again, looking at the data that we've collected and seeing where, we could improve, or what direction we want to go in or need to go in. So this is what the last page looks like on the chart. So the stretch goals, top 3 activities to work on, what SMART goals, specific, measurable, attainable, realistic timeline, and then a space for review and reflection. So Ms. Rachel, can you assist me in pairing people off here?
Sure will. You want groups of 2, right?
Yes. So I'll explain what we're going to do here. I know that we all come from different backgrounds and different clinical situations, work with different client populations. Again, what brings us all together is the problem gambling aspect of things, but I know some of us are in private practice, some of us are in agencies, some of us are in administration. So what I'd like to do is, I know Stephanie's a supervisor and Blanche, you're a supervisor too, right?
Well, yeah, I supervise students and clinicians, not in an agency, through my private practice.
Okay, so maybe we could have, and then are there any other supervisors here?
I supervise at Stutzman. This is Stephanie.
Yeah,
and
right, I know
have private
Stephanie,
practice.
yes, yes, I know Stephanie, you are.
I supervise the social workers at my school.
Oh, okay.
But that's for billing purposes, really, because they don't have their C.
Oh, okay. So why don't we do this? So the supervisors, Blanche, Stephanie, and Julie, if they could be paired off with somebody each, one person each, that can be their supervisee for the time being. We're going to have the supervisees sort of reflect on the chart that we just went over as far as the deliberate practice activities, and I can just sort of scan it as we go, but we're going to identify some strengths, weaknesses, areas of improvement in the various areas identified, identify 1 to 3 stretch goals. Even if you just get one, that's great. And then identify and develop some SMART goals to work towards those activities. And then the supervisor is going to just basically assist the supervisee as they assess some of their strengths and weaknesses as far as any of those areas that they want to focus on. And then they're going to assist their supervisee with identifying specific areas to improve upon and assist with identifying the stretch goals and SMART goals and developing some of those. So I'm going to sort of probably give maybe like, I don't know, 10 minutes or so. And again, I can scan through it as we go, but does anybody have questions? Right now? Okay. So how are we doing, Rachel?
So I can have the groups ready to go. And when you started talking and asking who was the supervisors, I was like, oh, let me make sure I can assign people to rooms. But
Okay.
do I need to do that, or can we do random assignment?
We can do random assignment, and so if if that doesn't work, then we can randomly assign. And when you get with your partner, you can decide between the two of you who's going to be the supervisor, who's going to be the supervisee.
Okay. There we go. And you guys can go to your rooms and you'll have 10 minutes in there.
Okay, we're back, huh?
Yeah, that wasn't enough time.
Yeah, I know. I'm realizing that I should be making these an hour and a half, and I apologize for the rush.
Yeah, and I'm not even going to be able to really engage. I have a 7:30 session. So
I
that I
know.
feel kind of rooked out of this because I really wanted to hear the feedback, and I had a great conversation with Sosa and would have liked to have shared that.
Oh.
So sorry, guys.
I'm
But
sorry.
it was nice meeting everybody. I really
Oh,
appreciate it.
Same here. Nice to meet you,
nice,
Glenn.
nice seeing you.
Thanks. I'll stay on for like 2 more minutes, but
Okay,
sorry.
okay. I'm sorry, everybody, for the rush and everything. And yeah, I'm realizing that I should give more time for these. This is my first time doing these, so bear with me. So group discussion. So anything that came out of what we just did as far as our role play, and any other of these questions as far as, do I have any questions about DP, how to implement and integrate it, barriers and obstacles to implementing it, integrating it, how would I address those or overcome those, and then what am I taking away? So anyone care to share about any of these things as far as what came out of the role play, or anything else that they might have questions on or comments about, thoughts? Did it feel like your typical supervision session, or was it a little different? Or
all right, so Julie and Julie played the role of the supervisor, and I played the role of the supervisee, remembering sort of, this is what I'm looking for. Considering everything that was being taught today, I thought that it was a good idea, for at least as a supervisee, to focus on the connection in the relationship. I think it was 4 common factors, 30% was relationship, so I wanted to sort of build on that. And I spoke to Julie. She gave me some pointers that I thought were very helpful. We talked about like the intake, asking questions such as, what are your expectations, that this is more like an interview to see if it's a good fit, sort of helping the client feel comfortable with engaging questions. So I thought it was very helpful. Learned so I felt good, new things. Thank you so much, Julie.
great. Yeah, I mean, there's so much when it comes to the therapeutic relationship, and it starts right off the bat from day one, session one, and laying out those expectations, and or, talking about the roles, and talking about, sort of road mapping, treatment planning, goal setting, all these things. So yeah, definitely. Any other questions, thoughts, comments? Anything else that we're taking away from tonight? Again, I know we're running over time, so I apologize. Well, So what is my plan? How do I plan to grow, develop, improve as a clinician? What can I do to help ensure better outcomes for my clients? Am I willing and able to take the time necessary to reflect, contemplate, be introspective regarding the services I'm providing and their impacts? Can I be mindful of, aware of, notice, and pay attention to the factors that most impact my effectiveness as a clinician and the outcomes or progress of my clients? So, you know, am I dedicated to continuous professional development and improvement, skill development, those kinds of things? So, and how do I plan to get there? So thinking about that. Now, there are some resources that you can learn more about deliberate practice from. There are articles, and again, I'll send these slides to everybody. A ton of articles by Scott Miller, and then there's a book by Scott Miller and Daryl Chow and Mark Hubble, Better Results Using Deliberate Practice to Improve Therapeutic Effectiveness. And then there are a ton of YouTube videos. If you search Deliberate Practice Scott Miller on YouTube. So references, and anybody who is willing and able, if they could put in the chat their answers to these questions as far as tonight's training. On a 0 to 10, how engaging was it? How informative was it? How clearly was the information presented? How useful, beneficial, helpful was it? How likely am I to utilize what I've learned?
So just overall, you're asking for one number to all of those?
Each of those.
Hello?
Yes.
I know we're done. I sent a message.
Okay.
Got it. Never mind.
You got
Thank you. Appreciate your
Okay.
time and these trainings. I missed the last 2 trainings because I was out of this country, but I appreciate it, and I will. I'm trying to get caught up now. But
Oh,
thank you.
okay. Yeah. So Alicia, yeah. Rachel said that there are recordings of the second and third and trainings, but
Right, I got it.
but yeah, as far as the CEUs, I don't think that you could get CEUs for that.
Not even partial for the 2 trainings I attended?
Oh, for the ones that you attended, yes, but
Okay,
you
but not
said
the.
It's for the ones that you attended, but I
Right.
can't give them out for the recording.
Got it. Understood completely. Okay. Awesomeness. Thank you. Have a good one.
okay. Well, thank you everybody for your time, attention, and participation. I appreciate you guys.